Welcome again to the Conquering Your Fibromyalgia podcast and YouTube channel here. Today we're going to be talking about a common question a lot of people have, and including those living with fibromyalgia and other chronic pain syndromes, and that's the use of opioids for fibromyalgia. We're going to look at a paper that was published in the Mayo Proceedings. It talks about the use of opioids and look at the review that they did, as well as other research to help understand more about the role of opioids, if at all, for use in those living with fibromyalgia. This podcast aims to give evidence-based information. Remember that while I'm a doctor, I'm not your doctor. All of your signs and symptoms should be discussed with your own individual physician. Today we're diving into a topic that has a lot of different levels of emotion and somewhat controversy, and it's the use of opioids in the treatment of fibromyalgia. What does the research say? Do opioids help, harm, or neither? And why, despite consistent guidelines advising against them, are they so widely prescribed? So why do patients with fibromyalgia often seek opioid medications? Fibromyalgia is at its core a central pain disorder or nociplastic pain syndrome. That means that the problem isn't in the muscles or joints. It's rooted in how the central nervous system processes pain. Patients experience chronic widespread pain along with fatigue, cognitive disturbances, also known as brain fog, that includes poor mood, memory problems, concentration, and focus. And as we've talked about, a lot of this overlaps with ADHD, as up to 70 to 80% of those living with chronic pain syndromes have ADHD, and those who tend to have more severe symptoms are much higher rates of having ADHD, as well as being neurodivergent in general, including being autistic. Other problems with these syndromes often are higher rates of mood disturbances, including anxiety and depression, although for many of my patients, it's much more about frustration and not so much depression. If they were able to have less pain and fatigue and brain fog and sleeping problems, they would feel much better. So it's understandable that patients often feel frustrated by their persistent pain. Often will turn to what are traditionally considered the most powerful painkillers, which are opioids. But fibromyalgia isn't like a sprained ankle or a broken bone. And the brain's processing system in fibromyalgia works very differently, which changes how opioids act, or more importantly, fail to act in these patients. So what do the guidelines say about opioids in fibromyalgia? Medical guidelines from virtually every major pain and neurology organization strongly advise against the use of long-term opioids with fibromyalgia. These include the American Pain Society, the American Academy of Pain Medicine, American Academy of Neurology, European League Against Rheumatism, the Canadian Rheumatology Association, and the British Pain Society. These recommendations are based on multiple converging lines of evidence, including the lack of efficacy, risks of harm, and the underlying biology of fibromyalgia, which doesn't respond to opioids the way nociceptive pain, like arthritis or injury-related pain does. Yet, despite these strong recommendations, opioid use remains shockingly high, with some large databases showing usage rates between 11% and 69%, depending on the patient population. Are opioids effective in treating fibromyalgia? The short answer is no. And this is one of the most important takeaways from the Mayo Proceedings article. There are no randomized controlled trials demonstrating that opioids are effective in fibromyalgia. 2 small studies using single infusions of morphine showed mixed results, and a Cochrane review on oxycodone in fibromyalgia found no studies meeting criteria for inclusion. Even more telling, real-world studies consistently show that fibromyalgia patients on opioids have poor outcomes. For example, in a 2-year longitudinal study, both opioids and non-opioid users improved over time, but those not using opioids had significantly better improvements in pain and function. Another 12-month observational study showed no differences in pain severity, but non-opioid users improved more in pain interference, insomnia, depression, and function. That suggests that while opioids might numb pain temporarily to some patients, they do not contribute to long-term improvement, may even hinder it. So, what does the brain tell us about opioids in fibromyalgia? Here's where it gets really interesting and where neuroimaging sheds some light. A PET imaging study using new opioid receptor tracers called carfentanil found reduced receptor availability in fibromyalgia patients, particularly in brain areas like the dorsal cingulate, the amygdala, and the nucleus accumbens. These regions play roles in pain perception and modulation. Two key interpretations emerge. Fibromyalgia patients may have elevated levels of endogenous opioids, the body's natural painkillers, at baseline, leading to down-regulated receptors, or they may simply have fewer opioid receptors, which limits their capacity to respond to both internal and external opioid. Either way, the result is the same. Opioids don't work well. In fact, those with lower receptor availability often reported more pain, not less. What is opioid-analgesia, and what is its effect on fibromyalgia? Opioid-induced analgesia is a paradoxical response where chronic opioid use actually increases a person's sensitivity to pain. Although it hasn't been directly studied in fibromyalgia, it has been shown in other chronic pain syndromes, in healthy volunteers receiving opioid infusions, and in animal studies. Given that fibromyalgia is already a condition marked by pain amplification, the risk of opioid-induced hyperalgesia may be particularly problematic. Essentially, opioids might be fueling the fire they are supposed to put out. How does Dr. Daniel Claw interpret this data? Dr. Claw has been at the forefront of fibromyalgia research for decades. He works at the University of Michigan, and he sees opioids not only as ineffective, but as potentially harmful in fibromyalgia. In his own words, the underlying mechanisms of fibromyalgia, central pain amplification, are not improved on opioids. In fact, opioids may worsen those mechanisms. He also points to strong evidence supporting the approaches, including the FDA-approved medications like duloxetine, milnacipran, and pregabalin. Also recommending exercise and physical activity, cognitive behavioral therapy, sleep optimization, and stress management. These approaches directly target the central pain processing abnormalities seen in fibromyalgia. If opioids don't work, why are they still so commonly prescribed? That's the million-dollar question. There are several reasons for this. Patient demand. In one survey, many patients reported opioids like hydrocodone or OxyContin as helpful, but this perception doesn't always align with objective improvements in function or pain. Physician prescribing habits. Some primary care doctors are still more likely to prescribe opioids, perhaps due to time restraints or having limited training in chronic pain management. Poor access to alternative therapies, where not everyone has access to CBT, physical therapy, or specialty care. So opioids often become the default. And there's a geographic variation where one study found a 5-fold difference in long-term opioid prescribing between states. Perhaps most disturbingly, once a patient starts opioids, they are less likely to ever be prescribed guideline-recommended medications. Are there psychological and social factors involved in opioid use? Absolutely. Multiple studies have shown that lower educational levels, unemployment, unstable mental health, substance use history, and prior suicide attempts are all more common in fibromyalgia patients using opioids, especially strong opioids. And for those of you who have listened to this podcast and YouTube channel, this may sound awfully familiar, as those who are neurodivergent are much more likely to have all of those problems. This includes ADHD and autism. Additionally, patients on opioids tend to score higher on measures like pain catastrophizing and lower on self-efficacy, meaning they feel less confident in managing their symptoms. These psychological traits may not only influence opioid use, but may also magnify the experience of pain. So what can we learn from this data moving forward? Fibromyalgia is a prototypical centralized pain syndrome, also known as nociplastic pain disorder. It teaches us that more drugs, especially opioids, are not always the answer. In fact, they can be part of the problem. Instead, we need to focus on multidisciplinary care, patient education, non-opioid pharmacological treatments, and above all, retraining the nervous system to process pain more normally. This means exercise, sleep, stress management, and building resilience and hope through active self-management strategies.
It's also important to recognize that chronic opioid use can cause lower testosterone levels and depression symptoms. This happens so insidiously that many people don't realize it, and that chronic fatigue, decreased motivation is related to the chronic opioid use, and getting off of that can cause such mental clarity by itself, let alone addressing other co-occurring conditions and comprehensive treatments.
So what are some final thoughts? Fibromyalgia challenges our traditional thinking about pain and how to treat it. And the data is clear, opioids do not help, and they often harm. But that doesn't make fibromyalgia untreatable, quite the opposite. We now have better tools, better understanding, and more options than ever before. It just requires a shift in the mindset, both for doctors and for patients. And I hope that this podcast goes a long way to help you in your understanding. Studies have shown just understanding of plastic pain syndromes has reduced on average the level of suffering by about 25%. What if you have fibromyalgia and you are currently taking opioids? What should you do? This is a deeply important and very personal question, and I want to approach it with the most empathy and clarity it deserves. First of all, I'm not your doctor, and you should talk about this with your individual doctor or care team that's managing this. But if you're listening right now and you're taking opioids for fibromyalgia, you're not alone. Between 11% and nearly 70% of fibromyalgia patients have been prescribed opioids at some point. And many of those prescriptions came before we fully understood just how ineffective and potentially harmful opioids can be for centralized pain syndromes like fibromyalgia. So if you're on opioids right now, the first thing I want you to know is this: it's not your fault. You haven't failed. The system failed to provide the right tools and education early on. Step number 1, don't stop cold turkey. Stopping opioids is dangerous and strongly discouraged. Withdrawal symptoms can be severe, potentially physically and emotionally, and abrupt discontinuation may increase pain and distress. Any decision to reduce or stop opioids should be done gradually and in partnership with your healthcare provider. Step number 2 is work with a knowledgeable clinician. Ideally, you will want to work with a provider who understands both centralized pain and safe opioid tapering. That might be a pain specialist, a rheumatologist, or a primary care doctor with training in chronic pain management. Then ask them to help assess your current dose and function, review non-opioid options that could be introduced as you taper, set realistic goals and timeframes, address their mental health, support needs, especially if depression or anxiety are also present. Monitor and adjust your tapering plan over time. A slow taper, sometimes just 5 to 10% over 2 to 4 weeks, can help your nervous system adapt. Many people worry that reduced opioids will make their pain worse. And in the short term, that might happen. But in the long term, studies show that fibromyalgia patients who reduce or eliminate opioids often experience better pain control, improved function, and less depression and insomnia than those who remain on opioids. Some key strategies to incorporate during or after tapering include medications that we've talked about, like duloxetine, milnacipran, pregabalin. These work through mechanisms that actually address central pain processing, not just blocking pain temporarily. There's the non-pharmacologic approaches we've talked about, aerobic exercise, whether that's gentle and progressive, starting slow and going up gradually, and cognitive behavioral therapy, mindfulness and meditation, sleep hygiene practices, and pain neuroscience education that we've talked about. These therapies may not deliver the quick fix of an opioid, but they help retrain your brain and nervous system for lasting improvements. And treat these associated conditions. People with fibromyalgia often struggle with overlapping issues like we talked about: depression, anxiety, poor sleep, trauma, ADHD, an autistic style brain and nervous system, all that make a powerful impact on the distress that people with fibromyalgia are going through. As part of this plan, address the mental health issues. Therapy, medications, and emotional support are critical. The sleep disorders, and if you haven't and there are symptoms of possible sleep apnea, make sure you get a sleep study. Look for symptoms of restless leg and periodic limb movement disorder, which are often co-occurring. And remember, as Dr. Daniel Pla has said, that fibromyalgia is not just about pain, it's about the entire experience of being unwell. Healing means addressing the whole person, not just the pain. And then remember to give it time and compassion. Transitioning away from opioids is not easy, and it's rarely quick, especially if you're on high doses. If somebody's on a relatively low dose, it's easier to wean down over time. Your nervous system may need months to recalibrate to if somebody's quitting another substance like nicotine, benzodiazepines, or if they are trying to get off nicotine or for smoking, is there takes some time, and that adjustment, and your brain has to develop new pathways. It's part of what we understand as neuroplasticity. And it's also important to build a sustainable plan, one that helps you function better, feel more hopeful, and with less pain and more control. And remember, you don't have to do this alone. Seek support from healthcare providers, support groups, pain coaches or therapists, and communities like this podcast, where many people like yourself are going through this together. There is real hope, and I hope that what you've learned today has helped you in growing your understanding, and recognize that living with fibromyalgia is often like being bound and tortured without any hope for pain and relief, and often there's no clear reason on why you're going through this. And hopefully, through what you've learned in the book, in the podcast, through this YouTube channel, helps you on your journey, going from not just living with this without any hope, but hopes that you can get better. One of my favorite group of patients are those living with fibromyalgia, because when somebody's had such suffering going on, not just for days or weeks, not just for months, not even just years, but often decades, often going back to childhood, being misunderstood. These chronic invisible illnesses are real, but there's also real hope for real pain, real fatigue, and real suffering. Take care. Hey guys.